Hello and welcome to another episode of our InnovAiT podcast. My name is Sadiya Ayaz and today I have the pleasure of having with me Irene Afreh-Mensah. Irene is a salary GP in Birmingham and she is about 2 years post-CCT now. She's also a member of the RCGP Midland faculty and a clinical tutor as well. The topic of our discussion today is going to be life post-CCT, the challenges of being a GP in the current climate, ideal GP model, and what makes general practice the best career in the world. Thank you once again, Irene, for being with us. It's really wonderful to have you and lots of interesting topics, areas that we'd like to discuss. How are you doing today?
Hi, Sadiya. Thanks for having me on. I'm doing well. I'm excited to get into this conversation. I think it's good to have these sorts of topics explored.
Absolutely. So it's been about 2 years, we were talking, since you have become a GP. How has that journey been for you?
Yeah, so life after CCT has been very interesting for me. So it's been a bit of a whirlwind. So I CCT'd in August 2020. So August this year will make 2 years. I'm just shy of 2 years post-CCT. And I picked up 7 clinical sessions as a salary GP. And then to do a couple of months in from that, I then picked up a local CCG fellowship, which essentially gives me the opportunity to work on a quality improvement project for my PCN primary care network. And so what I've focused on is a prescribing change, which will hopefully mean less time spent dispensing repeat prescriptions. And then about a year into being qualified, I picked up a clinical tutor role at the University of Birmingham. So it's been a whirlwind couple of months, but I am really enjoying it.
Brilliant. It sounds like you've got a lot going on and you're keeping yourself really busy along with the clinical sessions as well. And I do hear a lot of newly qualified GPs now taking on fellowship roles as well. How have you found that? What would you say have been the advantages of it for you and for your practice and the PCN as well?
Yeah, so within our CCG, so Birmingham and Solihull is the local clinical commissioning group, and they advertise the fellowship from a few months before you qualify. So as a trainee, I was aware that was an opportunity that could be available to me. And when I joined the practice that I currently work at, they were very open to me undertaking the fellowship. And I think what I enjoy about it, it's allowed me to remain those networks that you would have had as a sort of ingrained part of your vocational training schemes, and you'd get to catch up and meet up with peers. You don't necessarily get that formal time as much once you qualify. So that networking ability is what I really enjoy about the fellowship, and also just seeing how you can work with those within your practice. So because my fellowship is a pharmacy-based role, I've actually been able to work quite closely with our PCN pharmacy team to look at changing the way we do prescribing, just to try and reduce the burden for both clinical and admin staff in terms of repeat prescriptions.
Brilliant. That sounds like a really important and a really useful project that you've undertaken. What do you miss most about GP training?
Yeah, so I kind of alluded to it just now. I think I missed the half-day VTS, so the half-day study day where we would all get together. So pre-COVID, we would all get together in a set sort of training hub, have tutorials, a chance to just catch up, see how everyone was getting on. And sort of towards the end, it was that time period where me and my peers would get together and plan our revision, the last big exam, which pre-COVID was the CSA. But obviously that's now all changed. So I missed that the most. But interestingly, my sort of study group, we've kind of kept contact and we still regularly meet up, which I quite enjoy, just to touch base and see how everyone's getting on. I can say with much ease, the thing that I miss the least is the portfolio and the various work-based assessments that at times kind of felt onerous to try and complete.
So for GPs who are moving to a different area, is there a way that they can connect with local GPs in terms of being a faculty board member in the Midlands? Are there any certain groups or links that you might recommend for them to get in touch with so that they have that continuity of shared peer support?
Yeah, so that's a great question. So when we were in vocational training, we had a sort of WhatsApp group for all the trainees. And there are various WhatsApp groups at the moment that I'm a member of. So there's the Midland Faculty WhatsApp group, but there's also a First 5 network. So once you CCT, there's this idea of your first 5 years, you will go through a lot of changes and development. And so it's quite useful to sort of plug into those networks. And you can plug into those networks through the Royal College. I think there are first 5 specific sets, sort of CPD modules and things like that, particularly within the Midlands, that I know some of my colleagues do try and run to enable that level of networking to continue. So I would say keep contact with your peers, and then also look for first 5 networks in terms of opportunities.
There's a constant drive, I certainly find, Irene, for GPs nowadays, and especially newly qualified GPs particularly, to be doing so much, isn't there, from undertaking SPIN fellowships, like you mentioned, to co-authoring books, lecturing. Sometimes it feels like being just a GP isn't enough anymore. What are your thoughts on this, and do you think it's a good thing?
Yeah, so that's a great question. So I actually spent a long time sort of pondering on this question. And I think actually one of the benefits of general practice is the flexibility. So once you qualify as a GP, you have the flexibility to decide what do you want your career to look like. So if you're somebody where you just really enjoy clinical contact and you want to make sure that your working week is just mainly based on clinical contact, that's absolutely fine. But equally, if you're someone where you enjoy clinical contact, but you also like, for example, like myself, medical education or quality improvement, there is that flexibility to build those things into your week. And when I ponder on hospital colleagues who are consultants, because essentially we are seen as GP consultants once we qualify, they have a week that isn't just based on them seeing patients, for example, on the wards or in clinics or operating theatres. Some of them may be involved with medical school education. Some of them may be clinical supervisors. Some of them may be involved in research. So if the flexibility is there for hospital consultants, I think it should be equally as available for GP. So I think, to be honest, that there is no right or wrong. I think it's just a case of doing what works well for you.
I absolutely agree, and I think there shouldn't be that pressure that you have to be continuing to do more, but it's what gives you the job satisfaction. Now, I think a lot more of us are seeing how necessary it is as well. At the moment, as we know, general practice, we're probably going through the worst workforce crisis, experiencing how difficult it has been. In your view, what would you say is the greatest threat to general practice, and what can we do about it?
Yeah, that's a really great question. I think everybody knows at the moment, particularly all of us working in general practice, how challenging the last couple of years have been. I think, interestingly, with COVID, what it forced us to do was to think about the way we do consultations. So because of the public health need for safety, consultations had to switch from being majority face-to-face to telephone triage, and then balancing out the risks of those that needed a face-to-face assessment because of the public health risk. So I think what COVID has made us do is think about what's the best way to deliver healthcare within the primary care setting. So I think that in a way has been a good thing, because it's forced change a lot quicker than it may have happened, and encouraged management and partners to think about what's the best way to run a surgery. I think the biggest threat is probably the lack of retention of GPs. So I think that partly comes from the lack of recruitment, and I think that's more of a governmental issue in terms of their strategy for recruitment and retention. But I think on the ground, in terms of within primary care, what solution do we have to retention and recruitment? I think part of the issue is, or for me, what I found quite difficult was during the season where colleagues were being criticised in the media about their approach to the pandemic and their approach to the way they assess patients, I found there wasn't really quite an awareness of what does a general practitioner's day look like. And so I think the public perception is a GP sees patients the whole day. But the role is more varied than that. So yes, part of my day will involve seeing patients, whether that be a mixture of telephone triage and face-to-face. But it also then involves the sort of follow-up of those initial patients in terms of the investigations, whether that be blood tests or other imaging that you've requested and following that through. And then also the communication between ourselves and secondary care. So all of those things take place during the day. There may be meetings as well. And so I suppose what I would like is more of a public awareness that a GP's day is more than just seeing patients. And so if, for example, because I can appreciate patients become very frustrated if they're not able to access appointments. And often when I speak to patients, they'll say, oh, I've struggled to get an appointment. I say, it's the system that we're working with. I appreciate it. It can be quite frustrating. But there's never a day where my clinic is underfilled. So if patients are struggling to get appointments, it's not because GPs do not want to see the patients. It's just there is a capacity to what we can work within safely. And so I think for me, it's just that sort of awareness or patient education of the realities of what the day looks like. And then also, I suppose, one thing that I've always been told is we get 10% of the NHS budget and we do 90% of the work. So prevention is better than cure. So in primary care, what we try to do is to prevent the disease and keep people healthy, and reduce the likelihood of them running into complications and needing secondary care input. So I would just like people to appreciate that statistic. If you get 10% of the budget but you do 90% of the work, it's a really good resource. But also equally, that resource has a limit. And just to be more conscious of that, because I think there was a period of time where you would hear stories of people being abused by the public, people, whether that was verbal or physical, which isn't really nice in terms of the morale. So I think in terms of what can we do about the threat to general practice, it's this idea of retaining staff, which, as I say, I'll leave that to the government to think of clever ideas. But I think what would help is just public awareness of what the day looks like and the realities of the job. And if they can't get an appointment, it's not because we don't want to see them, it's because we've reached capacity of what's safe.
What's your idea of a perfect GP model?
That's a great question. I think perfection does not exist. And interestingly, I think most medics have a level of perfectionism within their personality. We want to do the very best we can for our patients. But I think a good model is one that involves a multidisciplinary team. So we have advanced nurse practitioners, we have clinical pharmacists, we've got a dynamic administrative team that will ensure that letters are appropriately managed so the things that are coming through to the GP is reasonable. So I think it's this idea of using different skill sets to ensure that the GP actually deals with what they need to deal with and makes the most of their skill set. Mm-hmm. So working within a team where everybody plays a role. I think even within my PCM, we have access to a sort of first contact physiotherapy or musculoskeletal service. So I also think as well, part of that model is patient education again, is making them aware that not everything needs to be dealt with by a doctor. So sometimes you can get resistance from patients, I don't want to see the advanced nurse practitioner, but she can adequately deal with your symptoms. If it sounds like you've got a urinary tract infection, they're very qualified to deal with that, for example. And also understanding that there's a safety net behind that if they are ever unsure about something, they can always then liaise back with the doctor to query and clarify and make sure that patients are safe. So I think an ideal model hones in on the skill sets of various members of the team to ensure that patients can access the care that they need when they need it.
Do you think we should be making GPs more or less resilient?
So resilience is an interesting word because I think during the first sort of lockdown, the pressure that we all faced was quite intense. And I suppose if I can reflect on my own coping strategies or resilience, I think what I had to find was a good balance between the pressures of work and also ensuring that whilst outside of work I had things that would refresh me. So I found exercise was quite a useful therapy for me. People will find different things that they find useful. I also found, talking to family and friends, which obviously we couldn't do much face-to-face during COVID, but those remote sort of contacts were very helpful. But yes, I do think resilience in terms of well-being is important, because you want a practitioner or GP who is well-rounded, so is able to be the very best in themselves, both mentally and physically, to ensure that they are then able to care for the mental and physical well-being of their patients. So often one of the common presentations I will consult with patients with is work-related stress. And it's interesting, those consultations, because sometimes the advice that you provide is things or strategies that I myself will use to try and cope with those work-related stress. So yes, I think resilience may be being inbuilt more into vocational training in terms of well-being and strategies to cope with stress. And even just being able to acknowledge the signs of stress, I think those are important.
Well, you've really highlighted some very important points there, Irene. I think that is essential, isn't it? And it's not something that we should, I think, back away from. As you mentioned, morale is exceptionally low at the moment in general practice for obvious reasons, but at the same time, we do need to look after our workforce. We need to protect our GPs and remind them that it is important to look after yourselves. As you say, if we don't look after ourselves, we then aren't able to do the best for our patients. What would you say was the best advice you were given during your training?
That's a good question. So I suppose in terms of the training, because there are two aspects to it, I would say with regards to hospital placements, be opportunistic. So what do I mean by that? There's a lot of assessments that you need to get done when you're in training. So particularly in your hospital posts, you're probably doing the assessment without knowing it. So what do I mean by that? So as a junior doctor, you may be asked to go and assess a patient and examine them. You might have your registrar with you while you're doing that examination. So after you finish reviewing the patient, it may be worth just asking that registrar, would you be happy to do that assessment with me as a mini-KEX, because they've observed you do something. Often as a junior doctor, you may see a patient, you make a management plan, you're not sure, you discuss it with your registrar if it's a little bit more complex. After you've had that discussion, the patient has been sorted, you can ask the registrar, would you be happy to do that as a case-based discussion with me? We've gone through some aspects of it, maybe we can follow up with a little bit more detail later on. But I think trainees can sometimes struggle to get assessments completed, but they're probably doing the assessments as they're doing the job. So just be opportunistic with those moments and try and get those assessments done. I think that will make things easier. And then I suppose when it gets to general practice, it's kind of a different level of training, because that's the environment that you're doing your training in, where this is the environment you'll be in when you qualify. So what does life as a qualified GP look like? So you're an independent consultant. So you see patients, you take a history, you examine, and you make a management plan. So if as a trainee you see a patient you're not sure, there's nothing wrong with being unsure. We would rather that you be safe. But what I would encourage trainees to do is to think about, okay, I know this patient probably has symptoms suggestive of angina, but I'm not quite sure what the management is. There are resources like nice clinical knowledge summaries, which even today I have open on my desktop. Every morning when I consult, I still use it now. So I just want trainees to get this idea that nobody's expecting you to qualify and be a fount of knowledge. You can qualify and still be unsure, but as long as you know that there are resources that you can draw on to help and guide you to manage a patient safely, that's ultimately what we want. So if you're unsure of something, you've looked for a resource, you're still not sure, don't be afraid to ask for help if you're not sure. and know that when you qualify, there will still be instances where there's that odd patient that's a slightly complex or medically unexplained, you're not quite sure what box it fits in. You can still discuss that with your other qualified peers once in a while.
Absolutely. Learning is such a continual process, isn't it, throughout GP training and far beyond that as well. And that's always a really important take-home point, that we continue to do that and utilise our colleagues, whether it's part of a peer support group or the other healthcare professionals we work with in the building, but reaching out for help, discussing cases, sharing our thoughts and concerns is always very important and necessary. Irene, do you think there is inclusiveness in general practice? This is something that, again, is a really important topic, and I feel we should also be addressing this. What can we be doing to address this, both as a college and also in the workplace, in your view?
Yeah, so I'm glad you asked me this question. Again, another great question. So I suppose, is there inclusion within the college? So as a member of the Midland Faculty Board, I can definitely say our faculty is very diverse in terms of our members. We have 2 equality, diversity and inclusion leads who passionately drive forward projects in terms of trying to increase inclusion and diversity within our faculty. Okay, so I can safely say I assume there are EDI leads throughout various faculties across the UK. A good friend of mine is actually an EDI lead in Essex, where she's training. So I do think the college is driving forward with an attempt to try and improve inclusion. For example, when it comes to things like South Asian Heritage Month or Black History Month, I have seen actively, particularly on the social media pages, an effort to push forward a program which tries to engage and celebrate the diversity of members. Specifically with regards to Black History Month, I think last October we ran a teaching sort of, Zoom session for ethnic minority trainees about some of the challenges that they may specifically face compared to their other counterparts when it comes to training. So these are things that are coming from the college with a desire to want to make sure that they are inclusive. But there's always more that can be done. So one of the things that I've recently just completed was I peer-reviewed a learning module which the college has brought out. And the learning module is about the theme of allyship, what that means and how that looks like in the workplace. So what I would say for the workplace is more of a drive to encourage those sorts of modules to be ingrained into the sort of mandatory modules that we are all expected to do, such as fire training or safeguarding. I think there are sometimes diversity modules on systems such as Bluestream, but I think more in-depth or more enriched inclusion modules that actually consider us to think about some of our unconscious biases will definitely enhance inclusivity within the workplace.
And what's your personal experience been like of inclusivity in the workplace?
Yeah, so I think within the workplace, I don't think I've ever had a problem from peers or patients, but I definitely know of colleagues who have had difficulties, maybe from patients, and sometimes not necessarily felt supported by management when they've raised these issues, but I think things are getting better.
Brilliant. What's been your greatest achievement to date, Irene?
When I think about what my greatest achievement is, it has to be completing GP training in the middle of the first coronavirus lockdown.
Yeah.
So it's been just over 2 years since the first lockdown, and the first lockdown came, the reason why I remember the date, it was the 20th of March, because my CSA exam was set for the 24th. And so I remember the week before, everyone was like, are we going to go into lockdown? Are we not? What's going to happen? And with the traditional exam, it required you to go to London to sit the exam. So that was a very anxious time for me. And then lockdown happened, and there was a lot of uncertainty. It wasn't clear whether I was going to get to CCT, how I was going to do any exam, or what the process would be. And one of the things that I found really invaluable was, because I was a member of the Associate in Training representatives on the national board, what that gave me access to was the ability to work with others to influence change. So we came together, we had various meetings, and there were various sort of surveys and things sent out to colleagues to say, would you like an exam? Would you like to just extend training? What would you like? And so once those opinions were gathered, we were then able to present that to the college at large and say, most trainees would like an alternative exam to be able to qualify. So then from there, as everyone is aware now, we've got the remote consulting assessment, which is an alternative to the CSA, which used to be a face-to-face. And so then, having gone from being involved in those meetings that helped to influence that change, it was also quite useful then being able to talk to peers locally and say, okay, this is what we're doing, these are the plans, because it was quite an anxious time. There was a lot of uncertainty. Yeah. And then from there, being able to actually sit the exam and pass when within the space of a couple of months, it was, okay, this is the process, these are the criteria for you to be able to pass, these are the sorts of patients we expect you to collate, and trying to collate that within the stress of the pandemic and make sure that you adequately shown that you're a safe consultant was very challenging, but thank heavens I got through it. And so I would definitely say, even though it's almost 2 years down the line, that for me was my biggest achievement, was being able to get that qualification in the midst of coronavirus, pandemic, and also during that time there was a lot of ever-changing daily guidance. So we were all learning about COVID, we were all learning, do we use nebulizers? No, we shouldn't use nebulizers because they're aerosol generating, but the week before it was fine. So yeah, definitely my biggest achievement was being able to CCT during such a hectic time.
Absolutely, and I think that is such an amazing achievement. I think speaking to so many trainees who were in a similar situation to you at that time, I think there was so much overwhelming anxiety and, as you say, uncertainty as well. Getting through your exams and the pressures of training and CCTing is a huge achievement for all trainees.
Yeah. I think one thing that I'd probably add on to that is to encourage trainees to think about more than just trying to get through the 3 years. So the fact that I was a member of the Midland Faculty Board as an Associate in Training rep or an AIT rep meant that I was in a position to be able to work with others to possibly influence change. Mm. And the Royal College, it can seem like it's just the society or the people that deal with exams, but there's so much more to the college. And you will only learn about these things if you get yourself involved. So you don't have to be a representative. You can just attend your local faculty board meetings as an observer, and just see the sort of discussions that they have. There's also groups like the British Medical Association, which is obviously our union, and there's also the local medical committees as well within the various regions, and all of these different groups play a role in your profession. So I would say try to go outside of just the focus of, okay, I need to do my work-based assessments, do my portfolio, reflections, exams, get my qualification and finish. I would say try and make those networks, because those are the avenues through which you realise, okay, this profession is more than just, okay, seeing patients. There's a complexity and a richness to it that you may not be aware of unless you expose yourself to these different groups.
I think that's a really valid point. I'm really glad you brought that up as well, Irene, because you're absolutely right. There is so much there that you can get involved in, and the college needs you. Whether you are still in training or after training, just getting in touch with your local faculty and the other organisations that you mentioned as well. Who is your inspiration in medicine, and why?
That's good. So I think I have a few. They interestingly are both women. So one of them is Dr Zoe Williams, a well-known GP who I would describe as a portfolio GP. And I think the reason why she inspires me is that she's a constant reminder of the fact that general practice is a job that gives you the flexibility to create the career that you desire. And also, as a woman of colour, she reminds me that anything I put my mind to, I can do it. Mm-hmm. And my second one would be one of my trainers from my previous practice, so Dr Clark. She's a well-seasoned GP She's a partner, but she also does lots of other stuff within the practice. So she teaches medical students. She also does coils and pessaries, all kinds of things. But I think what I admire most about her is her grit and the way she treats patients. So she's very thorough and a very good clinician and just a nice person. So those would be my two.
That's wonderful. Thank you for sharing that. Irene, what makes general practice the best career in the world?
General practice is the best career in the world because of the clinical variety. General practice is the best career in the world because of the flexibility, which is a word I've used quite a lot during this conversation. But I just love the fact that you can build a career that works around you, your family, your passions, your desires, your goals. So I think all the different hats that I wear now may not necessarily be the same in 5 years' time, but I like that because, you know, we as human beings, I think we grow, we develop, we change, and so your career can be flexible and move along with those changes as well.
Your advice to your trainee self?
That's a good one. Enjoy training. It's not very long. It can seem very stressful. I remember in training you just feel like there's so much to do, there's not enough time, but enjoy it. Enjoy the networking that comes with the VTS half-day scheme, and also network. I think that's really important. I think no one is made to be an island. So just having those connections, even when you finish, is a good way to touch base. So tomorrow I'm actually going out with my old VTS examining revision buddies. So yeah, keep those networks.
And then last but not least, in one word, how does the future of general practice look to you?
This is a good question. I've said this is a good question to every question you've asked me. Some really interesting discussions that we've had. I would say dynamic. And I choose the word dynamic because I want us to have a positive outlook. So everybody knows the job at the moment is very demanding, very stressful. But as with all things, there is a time and a season for everything. And I think things will get better. And I think this is the time where you can really make an impact in terms of if you think there is a good idea or there is a better way to do something, be open enough to share it with your colleagues or your peers, make that suggestion and see if that can be pushed forward. So yes, I think where we are at the moment is very challenging, but I think it will get better. And I think there will always be a place in the NHS for general practice because we use 10% of the budget and do 90% of the work.
Very well put, Irene. Listeners, we have had a brilliant conversation today with Irene Afreh-Mensah, a salary GP from Birmingham and also a member of the Midlands RCGP faculty. We have talked today about her inspirations in medicine and why. We've talked about why general practice is the best career in the world. Irene has shared with us her advice to GP trainees and what you can be doing, networking, progressing in your career as she has done and is continuing to do, and I'm sure has been an inspiration for so many. I've certainly felt very inspired by our conversation today. You've shared so many interesting facets of general practice, and I think these are always really important reminders for all of us who are listening to this, that general practice, despite the hurdles that we're facing, despite the crisis that we're having to endure, there is still so much satisfaction in the job, and I think we have to continually remind ourselves of the huge advantage that we are able to provide to so many people, sometimes unknowingly, but the changes that we can make to so many lives in a positive way is a really important reinforcement that I think we should never forget. Irene, once again, thank you so much. Any final words that you'd like to end our podcast with today?
Yeah, thank you so much for having me on, Sadiya. I've really enjoyed our conversation. And I think my encouragement to GP trainees is to just keep going. If you are finding anything challenging, reach out for support. There are so many networks that are willing to support you, but your skill set is invaluable, and every day you make a difference to someone.
Irene, thank you so much again.
Thank you.